Hello friends, welcome to the next series in diabetes. Mainly we'll be discussing about diabetic nephropathy and diabetic retinopathy today. So these are two important microvascular complications. Myself, Dr. Santosh Abraham, I'm working as a specialist registrar in diabetes and endocrinology at Scarborough General Hospital. Today, so we will discuss first about diabetic renal disease or diabetic nephropathy and then diabetic retinopathy. The topics under diabetic renal disease will be as follows. We'll discuss about the background, the definition of nephropathy, epidemiology, diagnosis of nephropathy, and role of various factors in the evolution of nephropathy such as hyperglycemia, hemodynamic alterations, genetic predispositions, and the impact of albuminuria, blood pressure, and cardiovascular risks on diabetic renal disease, and the treatment and the referral criteria for renal. So the background, it is a major cause of end-stage renal disease in worldwide, and more than 50 patients on renal replacement therapy in many mid and far eastern countries, and more than 20% in the UK also on RRT. Majority of diabetic nephropathy patients have type 2 diabetes, and cardiovascular morbidity and mortality is much greater, and many will die before reaching end-stage renal disease. Even before consideration of renal replacement therapy, many will die. So early planning is necessary in diabetic nephropathy. Definition is defined by the presence of dipstick positive proteinuria in a person with diabetes, which is equal to an albumin concentration of 300 mg per liter, that is total protein 0.5 gram per liter excreted. If it is more than 300 mg per day, it is overt or clinical nephropathy. Between 220 to 200 micrograms per minute or less than 300 mg per day are indicative of microalbuminuria or incipient nephropathy, but it indicates a high risk for future end-stage renal disease. But 30% of microalbuminuria or incipient nephropathy may spontaneously revert to normal, especially if the glycemic control is optimized. And these are the definitions of nephropathy based upon albuminuria. So if you are doing an overnight collection, between 20 and 199 micrograms per minute constitutes microalbuminuria, while more than 200 constitutes macroalbuminuria or clinical nephropathy. So 24-hour collection, if you're doing between 30 and 300 milligrams or 299 milligrams is microalbuminuria, more than 300 milligrams is clinical nephropathy. So this is the most important, which we usually do. And we also look at the ACR. If it is more than 30 milligram per millimole in Europe, it is clinical nephropathy. If it is more than 300 milligram per gram in the US, it is clinical nephropathy. And between 30 to 300 milligram is microalbuminuria in the US per gram. But milligram per millimoles, in milligram per millimoles, the ACR between 2.5 and 30 in males and between 3.5 and 30 in females is indicative of microalbuminuria. In this chart you can see the stages of CKD. So stage 1 is more than 90, more than 90 if the EGFR is more than 90. Stage 2 is between 60 and 89, and stage 3 is 30 to 59, and stage 4 is 15 to 29, and stage 5 is less than 15. So for stage 1, if they are not there is no microalbuminuria, they are at risk for diabetic kidney disease. But if there is microalbuminuria, they are probably having the diabetic kidney disease, both in type 1 and type 2. And if there is macroalbuminuria or clinical nephropathy, there is diabetic kidney disease. In stage 2 also, if the microalbuminuria is normal, or if there is no microalbuminuria, they are at risk, but they are at probable risk of having the diabetic kidney disease, both in type 1 and type 2 if they have microalbuminuria. And clinically nephropathy. Clinical nephropathy means macroalbuminuria signifies that they have diabetic kidney disease. So in all the stages, if you have macroalbuminuria or clinical nephropathy, you have the diabetic kidney disease. But in stage 1 and 2, if you have microalbuminuria, you have probable diabetic kidney disease both in type 1 and type 2. Whereas when you go to stage 3, you have probable diabetic kidney disease or possible diabetic kidney disease in type 1 or type 2 respectively if you have normal albuminuria. But if you have microalbuminuria in stage 3, it is diabetic kidney disease in type 1 and probable diabetic kidney disease in type 2. And in stage 4 and 5, if you have microalbuminuria, it is diabetic kidney disease. So in stage 4 and 5, if you have microalbuminuria or macroalbuminuria, it's all diabetic kidney disease. And in stage 4 and 5, if you have, even if you don't have normal microalbuminuria or macroalbuminuria, you have probable diabetic kidney disease in stage 4 and 5, irrespective of nephropathy, clinical nephropathy or microalbuminuria. The duration is a major risk factor for development of nephropathy in the epidemiology. As, in type 1, the incidence appears to be declining because of the improved management. Because the true date of onset of type 2 diabetes is hard to determine, the cumulative data are less reliable. So it appears that the progression of diabetic kidney disease in type 2 diabetes is usually worse, even though the data are not available. The Wikipedia showed that there was an annual incidence of 2% of microalbuminuria, and there was an increase of 3% per annum of clinical nephropathy in those with established microalbuminuria. So you can see the progression here. The prevalence is equal in men and women, and the rates are double for those of South Asians, and the cause is unknown. Diagnosis: a dipstick positive for protein or ACR on albumin creatinine ratio on 2 or more occasions over 6 months. A positive dipstick or a positive ACR on 2 or more occasions over 6 months. You need to exclude confounding causes. The confounding causes are here. It could be caused by vigorous exercise, UTIs, menstruation, or concentrated urine. It could all cause a false positive albuminuria. False negatives are dilute urine. And raised ACR in T1DM is due to diabetic kidney disease. Up to 15% of type 2 diabetes with microalbuminuria have atypical appearance on renal biopsy. Presence of retinopathy makes diabetic kidney disease and glomerulosclerosis much more likely. And non-diabetic changes in the renal histology are nephrosclerosis and tubulointerstitial changes. So they are not dependent on the diabetes. Nephrosclerosis and tubulointerstitial changes. Pathology: earliest feature is kidney enlargement. The mechanisms are tubular hypertrophy and hyperplasia due to glycosuria. It is not completely reversible with glycemic correction. Glomerular hyperfiltration returns normal if glycemic correction is done, but not tubular hypertrophy and hyperplasia. The hallmark is increased glomerular basement membrane thickness. It is due to accumulation of matrix material secondary to the hyperfiltration. And the GBM width continues to increase, and matrix accumulation also occurs in the glomerular mesangium, leading to diffuse glomerulosclerosis. And in advanced nephropathy, these form large acellular nodules called Kimmel-Still-Wilson nodules, and it represents nodular glomerulosclerosis. Ultimately, the glomerular capillaries are obliterated by matrix material. They become sclerosed and stop to function. So what are the effects of hyperglycemia? Hyperglycemia causes glycation of structural proteins. It makes them less easy to metabolize and alters their function. It increases the AGEs, the advanced glycosylation end products, and the AGEs are linked to micro and macrovascular complications. Hyperglycemia also induces the sorbitol pathway and the HMP pathway, which results in activation of protein kinase C, and it results in more oxidative stress, increased thrombosis, and alterations in blood flow. Both duration and severity of hyperglycemia are strong determinants of nephropathy. Hemodynamic alterations implicated in the genesis of diabetic nephropathy are as follows. There is dilatation of afferent glomerular arterioles to begin with. This causes increased glomerular capillary pressure, and hence there is hyperfiltration, and this leads to mechanical stress in the basement membrane. It stimulates the matrix production by cytokinins such as TGF-beta, and angiotensin 2 is a main player here. This hyperfiltration is associated with nephropathy in type 1 diabetes mellitus. But its role in type 2 is much less certain. And this hyperfiltration is no longer significant if the glucose is corrected in type 1 diabetes. Genetic predisposition and ethnicity. The nephropathy rates increase in certain ethnic groups such as the Pima and the Native American subcommunities, Australian Aborigines, non-Ashkenazi Jews. And rates are also higher in Afro-Caribbean and Asian populations, probably due to the increased insulin resistance in Asians. So what is the impact of blood pressure, albuminuria, and the severe risk factors on diabetic nephropathy? Albuminuria, its development usually is the first clinical sign of nephropathy and is associated with the gradual loss of GFR. The rate of increase of albuminuria is around 2%, that is very important, and once albuminuria exceeds an ACR of 10 mg per millimole, it is persistent, it will not reverse, and it shows established nephropathy. Thus the increase is around 2%, and when the ACR is more than 10 mg per millimole, it is persistent and established nephropathy. Blood pressure, they are proportional to the worsening of nephropathy in type 1 patients, and it could be, the blood pressure increase could be due to the nephropathy itself in type 1, while the blood pressure could be a causative factor in type 2 diabetes. So nephropathy usually increases the blood pressure in type 1 diabetes, while blood pressure could worsen diabetes nephropathy or make diabetic, or could cause diabetic nephropathy in type 2. Whether it is driven by the high blood pressure, the progression of nephropathy, we know that the high blood pressure in any way it will cause the nephropathy progression. So blood pressure management is critical in the prevention of end-stage renal disease. How about cardiovascular disease, its impact? So patients with nephropathy usually have a great increased risk of cardiovascular diseases because of the increase in blood pressure, and also due to increased insulin resistance and serum lipid abnormalities. So the mortality is increased at least twofold for patients with microalbuminuria. And Sharp has actually shown the effectiveness of lipid lowering therapy in preventing cardiovascular events in CKD stage 3 or more. How do you treat diabetic renal disease? Good glycemic control is one of the cornerstones. So it can prevent development of microalbuminuria with worse control, and also have a higher incidence, and also in those who have a higher incidence of retinopathy and nephropathy. So it can prevent the development of microalbuminuria, and thus it can lower the incidence of retinopathy and nephropathy. So two factors make hypoglycemia a risk in nephropathy. That is, the incidence of hypoglycemia actually increases in nephropathy. It is reduced insulin clearance and reduced hypoglycemia awareness. Blood pressure. Once the blood pressure rises above 140/90 in type 1 and 160/90 in type 2, it has been shown that renin-angiotensin blockers can prevent the development of microalbuminuria and overt nephropathy. But once overt nephropathy has developed, AC inhibitors in type 1 and ARBs, angiotensin receptor blockers in type 2, have shown to reduce the numbers developing end-stage renal disease. The target blood pressure set is less than 130/80 in patients with nephropathy, and in normoalbuminuric, normotensive people either with type 1 or type 2, there is no evidence to suggest that antihypertensives will prevent nephropathy. Treating the cardiovascular risk factors, so lipids, especially LDL, should be lowered to less than 2 millimole per liter in all patients with diabetes and CKD. This lipid lowering has now been shown to affect the rate of loss of GFR or albuminuria. And smoking, if stopped, will help preserve the renal function as well as improve the cardiovascular outcome. Diet. In type 1 diabetes, protein restriction can reduce the rate of GFR, albuminuria and mortality in people with established nephropathy, but it is not so much convincing in type 2 diabetes. Anyway, a dietary protein in content less than 0.8 gram per kilogram is suggested. In short, a multifactorial intervention including glycemic control, ACE inhibitors, aspirin, lipid lowering, smoking cessation, weight reduction, exercise, and antioxidant therapy, as shown by the STENO-2 trial, reduces CV morbidity and mortality in patients with type 2 diabetes and microalbuminuria. Thus, a broad clinical approach to management should be undertaken. So, when to refer to nephrology? Current CKD guidance from NICE suggests referral to all patients with CKD stage 4 or worse, that is eGFR less than 30. And if the rate of progression will indicate that they will develop ESRD in the next 2 years, they should also be referred for preparation for renal replacement therapy, because survival is better with careful planning. And those with stable CKD, no significant albuminuria, well-controlled BP and glycemia, normoglycemia, they don't need any referral. So this is the criteria for referral for nephro, that is CKD stage 4 or more, rapid decline of GFR, that is more than 5 in an year or more than 10 in 5 years, microscopic or macroscopic hematuria with active urinary sediments, other systemic diseases such as SLE or systemic sclerosis, blood pressure outside the target despite 4 drugs or more, heavy proteinuria more than 1 gram per day, or ACR more than 70, and family history of genetic cause of kidney disease like polycystic disease, and if there is any renal artery stenosis suspected. Does the renal and transplantation and pancreas transplantation has any effect on survival? Survival in those requiring renal replacement therapy is best for those who receive a renal transplant, although with non-diabetic renal disease, they tend to fare rather than those with diabetic renal disease. So even though the renal replacement therapy will work for in the form of a renal transplant will work for diabetes patients, it won't do much better than in patients with non-diabetic renal disease. Also, pancreas transplantation has not shown any improvement in survival, but there could be an improved quality of life. Now coming to diabetic eye disease, here the topics covered will be epidemiology, classification of diabetic retinopathy, pathology of retinopathy, background diabetic retinopathy, pre-proliferative retinopathy, proliferative retinopathy, and diabetic macular edema, eye screening and criteria for ophthalmology referral, the risk factors in retinopathy, medical treatment, surgical treatment, and alternative to surgical treatment. So retinopathy is a complication of diabetes. It results from damage to small blood vessels, and it occurs usually in 10 years after the onset of diabetes. So in type 2 diabetes, maybe you can find it early because the diagnosis, the onset of diabetes may be much earlier and it could be missed. So it is one of the leading causes of blindness in working age population, and cataracts are also more common in people with diabetes. This is the classification and features of diabetic retinopathy. When you come to the background retinopathy, also called R1, it is characterized by microaneurysms, hemorrhages, hard exudates, and soft exudates or cotton wool spots. In the pre-proliferative or R2, there are multiple blot hemorrhages, edemas, venous bleeding, and venous duplication. And the proliferative retinopathy, there are NVD, NVE. NVD means new vessels on the disc, and NVE means new vessels elsewhere. Plus there is fibrovascular proliferation with or without tractional RD or retinal detachment, rubeosis iridis with or without glaucoma, and pre-retinal or vitreous hemorrhage. So you can see the burden increases here. And maculopathy is defined as exudate within one disc diameter of the center of the fovea, or with group of exudates within the macula, or any microaneurysm or an hemorrhage within one disc diameter of the center of the fovea, and associated with a decreased visual acuity, and retinal thickening within one disc diameter of the center of the fovea. So maculopathy here means exudate within one disc diameter, group of exudates within the macula, microaneurysms or hemorrhages within one DD if associated with a reduced VA, and retinal thickening within one disc diameter. Pathology. One of the first histological changes seen is thickening of the basement membrane and loss of pericytes, and they form acellular capillaries. Breakdown in these endothelial tight junctions lead to increased capillary permeability, and the microaneurysm is the hallmark of retinal microvascular disease in diabetes. The natural progression is with increasing retinal ischemia from background to pre-proliferative to proliferative, and ultimately to sight-threatening retinopathy. Maculopathy can occur at any of the stages, but usually it occurs in more advanced disease. So microaneurysms are asymmetrical dilatations of the capillary wall when it is weakened or damaged, and it follows the loss of the pericytes, and there is increased hydrostatic pressure. Smooth muscle cell death, capillary weakening, and occurrence of intraretinal microvascular abnormalities, usually called edemas, and impaired autoregulation are the features of retinopathy. Let's come to background retinopathy. Here you see capillary microaneurysms. These are the earliest feature, and you see them clinically as red dots, and these can be difficult to distinguish from microaneurysms the dot hemorrhages can be difficult to be distinguished from the microaneurysms. Small intraretinal hemorrhages or bloats are also occur. And hemorrhage in the nerve fibers layer are often flame-shaped. These are the flame-shaped hemorrhages. And with increased capillary leakage, hard exudates, which are lipid deposits, can also be seen. A cotton wool spot is a delay in transmission along the axoplasm of the nerve fiber layer of the retina caused by ischemia. So it's a delay in the transmission along the axoplasm. It was once considered a pre-proliferative feature, but since it is not a good indicator of progression to proliferative retinopathy, it is now included in the background category. So here you can see the background retinopathy with hard exudates here, and you can see microaneurysms and also hemorrhages here. Now coming to pre-proliferative retinopathy, as the ischemia increases, the retina will show increased numbers of blot hemorrhages, which are found in the deeper layer, and intraretinal microvascular abnormalities, the IRMAs, now become visible. They are tortuous intraretinal vascular segments varying in caliber, and these are derived from remodeling of retinal capillaries actually, and small collateral vessels develop in the areas of this microvascular occlusion. So IRMAs are basically from retinal capillaries, whereas venous beading and venous duplication is confined to the veins. Venous beading is localized increase in the caliber of the vein, whereas reduplication is a dilatation of a pre-existing channel or proliferation of a new channel. And venous reduplication is approximately the same caliber as the original vein, whereas in the beading the caliber is increased. So you can see venous beading here, and there is the IRMAs here, the anomalies. So factors indicating progression are to proliferative DRR, you have a 4-2-1 rule here. If there are 4 quadrants of severe hemorrhages or microaneurysms, or 2 quadrants of IRMAs, or 1 quadrant with venous beading, with any one of these, you have a 15% of risk developing proliferative diabetic retinopathy in 1 year, and if there are 2 present, it increases to 45%. So the factors are 4 quadrants of severe hemorrhages or microaneurysms, or IRMAs in 2 quadrants, or venous beading in 1 quadrant. So you can find that venous beading is an important risk factor in the progression of retinopathy to proliferative retinopathy. Coming to proliferative retinopathy, so they are characterized by NVDs and NVEs. NVDs at or near the optic disc. So they usually develop from the venous circulation and grow forwards in the vitreous gel. But they can also develop from the arterial circulation. But the NVDs and NVEs are mainly from the venous circulation. So what is NVDs? NVDs are new vessels on the disc, and these are any new vessel developing at the optic disc or within 1 dd of the edge of the optic disc. NVE are defined as new vessel developing more than 1 disc diameter away from the edge of the optic disc. So within 1 dd of the optic disc you have the NVD, and if more than 1 disc diameter away from the optic disc you have the NVE, new vessels elsewhere. And the Diabetic Retinopathy study group recommended prompt treatment with PRP, pan-retinal photocoagulation, in the presence of high-risk characteristics, which reduce the 2-year risk of severe visual loss by 50% when you treat it. So the high-risk characteristics are the presence of pre-retinal or vitreous hemorrhage, eyes with new vessel near the disc equaling or exceeding 1/4 to 1/3 disc area in the extent with no hemorrhage, and new vessels elsewhere equaling more than half disc area with hemorrhage. So it's a complex criteria, but the presence of preretinal or vitreous hemorrhage and eyes with NVD or NVE, usually NVE more than half disc with hemorrhages, usually are high risk factors, and prompt pan-retinal photocoagulation is needed. So you can see in this proliferative retinopathy slide, you can see the new vessels elsewhere along with some venous bleeding, and there is also severe macular edema actually here. Here you can see the NVD, that is the new vessels on the disc, and some cotton wool spots. You can see the new vessels here, new vessels elsewhere. Also there are some new vessels on the disc also here. It's very close to the disc here. And finally, about diabetic macular edema, it is of three types: focal, diffuse and ischemic. In focal, there is leakage around the microaneurysms, from the microaneurysms in a circinate pattern. In the diffuse, there is generalized breakdown of the blood-retina barrier, and there is early leakage from the entire capillary bed. And sometimes there is CME also, cystoid macular edema also along with that. And in the ischemic variety, ischemic form, there is enlargement of the foveal avascular zone. About the clinically significant macular edema, CSMO, it is defined as thickening of retina at or within 500 microns of the center of the macula, or hard exudates at or within 500 microns of the center of the fovea, or a zone or zones of retinal thickening, one disc area or larger, at any part of which is within one disc diameter of the center of the macula. A zone or zones of retinal thickening, one disc area or larger, or any part of which is within one disc diameter of the center of the macula. And focal retinal coagulation is suggested for central clinically significant macular edema. So CSMO is thickening of the retina at or within 500 microns of the center of the macula, or hard exudates or 500 microns or at or within 500 microns of the center of the fovea, or a zone or zones of retinal thickening in one disc area or larger. And eye screening, NICE recommends for those with type 1 and type 2 that they be screened at the time of diagnosis and at least annually after thereafter. The method used is two-field mydriatic digital photography, and fixed locations and mobile units are used here, and monitoring is by quality assurance standards and key performance indicators. In visual acuity, you should remember that high blood glucose can lead to false myopia and low blood glucose can lead to hypermetropia. These are the reasons for referral to the ophthalmologist and the timings also. So immediate referral for rubeosus iridis or neovascular glaucoma, vitreous hemorrhage, and if there is retinal detachment. So hemorrhage, retinal detachment, vitreous hemorrhage, and rubeosus iridis, immediate referral. Urgent referral in proliferative retinopathy, routine referral in pre-proliferative and maculopathy, and routine non-diabetic retinopathy referral is in cataracts. If there is no retinopathy, annual screening is recommended, and also for background retinopathy, annual screening is recommended. In background retinopathy, you need to inform the diabetes care team as well. So this is very important: rubeosus iridis, vitreous hemorrhage, and advanced and retinal detachment. Immediate referral you need to do, and in less than 2 weeks you need to refer all the cases of proliferative retinopathy, and routine referral is needed for the pre-proliferative and maculopathy. The risk factors for developing diabetic retinopathy, there are modifiable and not modifiable risk factors. So modifiable are obviously glucose, blood pressure, lipids, and smoking. Smoking is in type 1, okay, it's not in type 2. And non-modifiable are duration, age, genetic predisposition, ethnicity, and pregnancy. You cannot modify all these. So the medical treatment revolves around glycemic control, blood pressure, lipid control, antiplatelets, and lifestyle advice. Of these, we all know that if the glycemic control is improves, the progression and the onset of diabetic eye disease is delayed. Whereas if it worsens, if the glycemic control worsens, it could hasten the progression of diabetic eye disease. And diabetic retinopathy can worsen when you suddenly improve the glycemic control. So there should be careful monitoring of the retinopathy, especially in pregnancy. And UKPDS also showed that blood pressure control is vital to reduce the onset and progression of diabetic retinopathy. About lipids, the use of fenofibrate in type 2 diabetes might reduce the need for laser treatment of diabetic retinopathy in a 5-year period. That is a field study which showed that. And elevated lipids are associated with macular exudates, and partial regression of exudates may be possible by reducing these lipids. Antiplatelets, there is no convincing evidence. Lifestyle advice, stopping smoking will reduce the risk of retinopathy in type 1, not in type 2, type 1 only. And no effects on stopping alcohol or physical activity. So stopping smoking only in type 1. Surgical treatment of diabetic eye disease, use the laser panretinal photocoagulation for the proliferative types. So these are the specifications: 1000 to 200 to 1600 argon laser burns of 500 microns spot size. It can be performed in 2 or more episodes, no more than 2 weeks apart, and no more than 900 burns should be applied in one session. It's usually applied with local anesthesia. So this laser energy is absorbed by choroid and pigment epithelium, and it and the treatment for this CSMO will reduce the visual loss by 50%. You know, it is by the focal laser. And it is very important to educate the patient that it will prevent further deterioration in vision, especially in maculopathy, but it will not restore vision. So if the patient believes that they are going to regain the sight, it is not going to happen, but it will prevent further deterioration. Coming to vitrectomy, the indications are: if there is a vitreous hemorrhage which doesn't clear, there is a large subhyaloid macular hemorrhage, a tractional retinal detachment, which is very important indication, and then when there is a combined retinal detachment, progressive severe fibrovascular proliferation, etc. Alternatives are intravitreal VEGF inhibitors. As you all know, angiogenesis and neovascularization is associated with the VEGF. So 3 potential inhibitors, pegaptenib, ranibizumab, and bevacizumab, are found to be effective. NICE appraiser in 2013 has now recommended ranibizumab in certain cases of macular edema. Potential complications of intravitreal VEGF inhibitors are endophthalmitis and retinal detachment. Thanks for watching this presentation.